Okay. Hi, everyone. So my name is Caroline Lee. I'm one of the gynecologists at the BC Women's Center for Chronic Pelvic Pain and Endometriosis. And I previously was also working at the BC Center for Vulvar Health. So thank you for inviting me again for a second talk and on gynecological pain conditions. So again, I'd like to begin by expressing gratitude that I'm able to live, play, and work on the unceded territory of the Coast Salish peoples, including the Musqueam, Squamish, and Tsleil-Waututh nations. And I really feel that being here is what allows me to pursue my passion for my work. This is the same disclosure as before, but I can say that this is not going to have any bearing on my talk today. And so I wanted to begin by discussing some themes in gynecology, and you'll probably find a lot of parallels with chronic fatigue syndrome and fibromyalgia as well. And so there was a study that I read during my master's where it was talking about how adolescent teenagers perceive symptoms suggestive of endometriosis among their peers. And so they completed a focus group of individuals aged 14 to 18 and placed them into focus groups discussing 4 different scenarios. And some of the themes that came up was how there's an inequitable gender norms, for example. So what they found was that menstruation is often not discussed because it's found to be, in quotations, gross to men. Also, the invisibility of the disease. So, for example, if someone had diabetes versus menstrual cramps, people are more likely to be understanding about diabetes because they know more about it. But instead, with what happens with endometriosis type pain is people are told to toughen up, to get through it, and to keep working. Also, one thing that really struck me was the fact that depression, which has its own stigmas, actually is seen to be less stigmatized than menstrual issues. And then the fact that sex is often thought to be, is supposed to be pleasurable. But if you don't have that experience, then it can be quite stigmatizing for those individuals. And this is in adolescence, so it starts really early. So given this, what we are planning to do is review chronic overlapping pain conditions just briefly. And then we're going to be discussing pelvic pain conditions and our approach at BC Women's Center for Chronic Pelvic Pain and Endometriosis. And we'll also be discussing vulvar pain conditions and the approach at BC Center for Vulvar Health. So chronic overlapping pain syndromes, I know that a lot of people already know about this, but it's a group of chronic pain conditions that occurs with each other in high frequency and has a common underlying cause. And so what will probably be familiar to you is the chronic fatigue syndrome, fibromyalgia. But from our perspective, from the gynecological perspective, what we deal with is endometriosis and vulvodynia. The underlying cause is thought to be related to central sensitization. So it's a heightened activity of the brain and spinal cord, which composes a central nervous system in response to pain. And so a really good way that I've heard it being described before is likening it to living in a haunted mansion where your body is always on high alert for pain. And so it can be, what that leads to is that there is a more exaggerated response to any pain. And non-painful signals can be seen as painful. So for example, a Q-tip might become quite painful, might be felt as being painful in certain areas. And then there's a bit of generalization of the pain. So in my world, it might start in the uterus, but then it can also spread towards the bowel and the bladder, even when there's no endometriosis there. And so in the gynecological world, like I said, endometriosis, adenomyosis, and vulvodynia are very common pain conditions. And it's often associated with muscle pain, where you get pelvic floor spasms and pain. And it's because if you look at the organs here, they're all lying on top of the pelvic floor muscles, which kind of serves as a hammock for all the organs. And so when the uterus is such a big source of pain, your body's natural inclination to try to brace against it. And so when you try to brace against it, the muscles are much more contracted. And then that leads to a buildup of lactic acid and then pain that way. We can also get abdominal wall trigger points. I know you guys have talked about abdominal wall trigger points in the past, but this can also occur in response to gynecological conditions. And what we also see is that there's back and hip pain because of the way that you're holding yourself. And the commonly seen conditions that overlap with our gynecological conditions is irritable bowel syndrome and painful bladder syndrome. And because my lens is from the endometriosis point of view, In people who have endometriosis, there's an 18-fold increase in having painful bladder syndrome, a 16-fold increase in vulvodynia, IBS at 5-fold, and fibromyalgia at 4-folds. So diving into the pelvic pain conditions, we'll start with endometriosis. And so what is endometriosis? Before we get into that, I just wanted to show this diagram on the right. And so here you can see that this is the uterus right here, and the endometrium is where you get your period from. And so endometriosis is a chronic inflammatory condition that involves the growth of endometrial tissue, so the endometrium, outside of the uterus, and it grows in response to estrogen. And so what ends up happening is that the tissue can land in this area around the support structures for the uterus, and it can be inside the ovaries, and sometimes it can be even in distant places like the lungs. And what it does there is that in the first half of the cycle, as we talked about before, there's an estrogen predominance, and during that time, endometriosis grows. And then when you get the withdrawal of the hormones, estrogen and progesterone, you get bleeding not only from the endometrium, but also from the tissue. And so there's bleeding within, microbleeding within the tissue itself, and that leads to inflammation and pain as well. How common is it? It occurs in about 11% of reproductive female individuals, and it's even increased to a higher level if you have infertility or chronic pelvic pain at 20 to 50%. How does it present? The common symptoms are painful periods, painful sex, painful bowel movements, daily pain, and pain with pain. And when you look at that, you don't think it's that big of a deal, but when you live with the pain that is associated with endometriosis, what we can see is different individuals have periods that are so painful that you're missing work because of this, and that's happening on a monthly basis. And what also happens is that people are completely bedridden during the time when they do have the pain. And so you can see how that would be very disruptive to work, to school, and to just even having a social life. The other thing is painful intercourse, and this is more pain with deeper intercourse. And it gets to the point where people become so fearful of intercourse that they just avoid it altogether, and that can lead to it can lead to relationship breakdowns as well. Daily pelvic pain seems to occur more often when this has been going on for a long time, and that's when the nervous system is often involved. And then the other components tend to be related to IBS and painful bladder syndrome. For infertility, that's the other way that it can present. And so if you have endometriosis involving the ovaries, what can happen is that you can have a low egg supply for your age, and then blocked fallopian tubes if it's really if the disease process is really significant. And then it can actually lead to a little bit of a delay in achieving pregnancies in those with lower stage endometriosis. How is it diagnosed? The typical first steps is to undergo a physical examination to see if there's any signs of advanced endometriosis, and ultrasound, and then magnetic resonance imaging is considered, or MRI is considered optional. But the gold standard for diagnosis is to do keyhole surgery, and this is the view that I normally get when I do keyhole surgery. And what we do is we pick up some of the lesions that look like endometriosis, and it can be quite subtle. And what we do is we send this off to the pathologist or someone who can look at everything under a microscope to confirm the diagnosis. Endometriosis is staged between 1 to 4, with stage 1 being the least severe and stage 4 being the most severe. And when you get to stage 4, disease, it often involves the bowel. It can involve the ureters, which is tube connecting the kidneys, the bladder, and then the ovaries as well. So this is a very surgically complex situation that can only be handled that usually only are able to be handled by endometriosis surgeons. But we'll talk about that in a second. And so the interesting thing is that we find that a lot of people think that if you have more pain, that you have worse endometriosis, so higher stage endometriosis, but we actually find that that's not the case. And sometimes stage 1 and 2 endometriosis is the most severe. It presents with the most pain or issues with infertility. So this is just more of a language by which we can convey the severity of the endometriosis, but not the severity of the pain. What are some challenges in endometriosis? There's often a diagnostic delay. So the time from when you first get the symptoms to when it's actually diagnosed, it can be anywhere from 4 to 11 years. And the reasons for diagnosis delay is because of dismissal, normalization, or reduction of symptoms. And this can be by anyone. So it could be by partners, parents who say you should just suck it up, healthcare professionals who normalize it, or society itself. The symptoms can be vague, and then there's a fear of stigma. And it's because there's a fear of rejection if you were to bring it up with your healthcare professional. But diagnostic delays can be quite difficult on a person's life, of course, because the longer you have pain that's untreated, the more likely you are to develop central sensitization and other pain conditions. So there's increased likelihood of developing more severe pain that ramps up, and then increased likelihood of developing other conditions like IBS and painful bladder syndrome. In terms of reduced fertility, it can be, first of all, like what we talked about earlier, but also if you're not aware of it, you might be losing out on your window of fertility. Another thing that can happen is that people might decide, I want to get my uterus out because it's so painful, but then they're having to sacrifice the dream of having a child. And so people can be driven to that extreme where they're willing to sacrifice the dream of having a child because of pain. It can impact the education and work that someone completes or attains. So it can be related to missing school all the time, missing work all the time, not being able to concentrate at work, needing to go part-time to cope, losing out on chances for promotion, giving up a favorite job, or choosing a less stressful job so that you can function at work. It can impact relationships, both socially and also in loving relationship too. So a lot of people end up isolating themselves, may have a sense of poor body image, social withdrawal, and this leads to reduced friend and family support. And it also can impact relationships due to sexual distress, depression, and self-image issues. So overall, can lead to a poor quality of life the longer it goes without being diagnosed. And I felt that this diagram really shows that point really well. And so the consequences of not having any endometriosis is achieving more of your goals. But if you aren't diagnosed, this is what can happen, this trajectory where you never achieve the same level of what you aspired to. With endometriosis, the other issue is that there's a surgical complexity associated with it. So when someone has stage 4 endometriosis, there's a risk of what's called open and closed surgery, which is where you go in and aren't able to complete the full surgery. And this is obviously distressing for the individual, but also for the surgeon themselves, and it leads to delay in appropriate surgical care. There's also a limited availability of reliable imaging for prediction of more complex disease. And we find that if you complete the ultrasound in someone who's trained for endometriosis, it's more predictive, but the average ultrasound is not predictive for advanced disease. MRIs can also be more reliable, but again, it often depends on the reader. So you need someone who has training in endometriosis to get a really reliable picture. There's also a worldwide limited availability of endometriosis specialists. In Vancouver, we have about 10 individuals for all of Vancouver itself. So this leads to a lot of delays in diagnosis, but also delays to proper surgical treatment. And we'll go over some of what we do at our center afterwards. So in terms of, well, we'll move on to adenomyosis now. So with adenomyosis, it's a condition that I often relate to endometriosis, and it's a chronic condition where endometrial tissue grows outside of grows in the muscle of the uterus. So it's very similar to endometriosis, except that the endometrium, where your period comes from, grows in the muscle, as you can see here. How common is it? It affects about 20 to 30% of all reproductive female individuals and 50 to 90% of those with endometriosis. They often seem to coexist with each other. And then the risk factors for adenomyosis include increased age, if you've had more pregnancies, miscarriages, or terminations, pregnancy terminations, and then if there's been uterine surgery like C-sections. How does it present? Pelvic pain is most common, so the painful periods. You can get daily pelvic pain and pain with intercourse as well. The other factor of this that is not often seen with endometriosis is an abnormal bleeding pattern. So you can get heavy menstrual periods, very, very heavy periods, bleeding between your periods, or spotting before and after periods. And then infertility can also be seen, but this is most common with types where like this, where it's just localized to a certain area. How is it diagnosed? Again, first steps is ultrasound and MRI is optional. But the gold standard is actual removal of the uterus and confirming adenomyosis under a microscope. So you can have some suspicions that someone has adenomyosis, but you can't definitively say they do until the uterus is removed. Sometimes the removal of adenomyosis alone, if you just remove those isolated pockets, you can make that diagnosis, but that can only be done in the hands of advanced surgeons as well. What are some challenges in adenomyosis? Again, like I said, the diagnosis is made based on surgery. And the ultrasound is becoming more useful as a diagnostic method, but there's a limited number of radiologists with training in this. Magnetic resonance imaging also provides a suspicion rather than confirmation, but it's seen as being the most superior method of diagnosis. But in Canada, there's limited access to MRI. Yeah, and then like a lot of the issues with adenomyosis is similar to endometriosis. And I wanted to just touch on polycystic ovarian syndrome just briefly. There's a bit of controversy about whether or not this is a pain condition, but I wanted to just go over this because of its association with chronic fatigue syndrome and myalgic encephalitis. What is PCOS? It's a complex hormonal condition associated with chronic inflammation and insulin resistance. It's often associated with disrupted ovulation, so the cycles don't occur the way we would want it to, as we saw it from the previous talk. And then you get this excess exposure to estrogen because your body's trying to ovulate, but it never does. And so it just continues in the follicular phase. And we talked about earlier about how chronic estrogen exposure can be associated with more pain and a chronic inflammatory state. So this is likely why there may be some association with pain itself. So how common is it? It impacts about 4 to 20% of all reproductive female individuals and 40% of those with female infertility. How does it present? So there's abnormal bleeding patterns, so irregular or no absence of periods completely. You can also get continuous bleeding and heavy and long periods associated with it. Another hallmark is the fact that you may have signs of excess male hormones. So acne can be common, excess hair around the face, chest, or back in a male pattern fashion. And you can get male pattern balding or thinning of hair, just kind of at the temple region here. Infertility impacts about 40% of those with PCOS, and this is thought to be due to a lack of ovulation. How is it diagnosed? This is controversial. There's 3 different criteria that are used. The most common criteria is the Rotterdam criteria, where you need 2 of 3. So 1 would be excess male hormones, and that can be seen on labs or by the clinical exam with acne and excessive hair growth. You have to have irregular or no periods and the appearance of what's called polycystic ovaries on ultrasound, and I'll show you what that looks like on the next slide. Another more is a new criteria, more recent criteria, is just relies on excess male hormones and ovarian dysfunction, so lack of proper ovulation. And this is what the ultrasound usually shows if you have polycystic ovaries, and we call it a pearl on a string appearance. And this is due to the attempts to try to ovulate, but with it being disrupted. So the recommended evaluation is to start by looking at the menstrual irregularities and getting a history on that, looking for signs of excess male hormones, or be it the excess hair growth or acne, an ultrasound, and then can do a hormonal profile for testosterone, FSH, and LH levels. And then because there's a component of insulin resistance, we usually recommend looking at sugar levels, insulin levels, and cholesterol levels, lipid levels. The challenges in PCOS is that there's a stigma due to its association with insulin resistance. So it's often seen as a condition of excess weight and insulin resistance only, rather than being a pain condition. So this dismissal can also contribute to a sense of poor image, depression, and poor quality of life, because I find that the more often you're dismissed, the less likely you are to believe in yourself and your conditions. The association with poor quality of life, we can go into a bit more detail, is that there's often a negative body image due to their potential relationship with obesity and excess hair growth. There's an increased likelihood of anxiety, anger, and psychological distress. And then decreased sexual function. So there's a 2 to 3 times increased risk of that, where it's associated with decreased arousal, lubrication, orgasm, and satisfaction. And then bodily pain, like I said it before, is not universally acknowledged as a chronic pain condition, but there's an increased overall pain perception in the studies that have been completed. So individuals are more likely to experience migraines, fibromyalgia, rheumatic arthritis, and IBS. And the factor that might tie all this together includes the chronic inflammation that we talked about. So it seems to have a direct impact on the nervous system to sustain pain. There's also the presence of abnormal fat cells that promote insulin resistance and thus inflammation. And then the long-term outcomes, some of the consequences of PCOS may be high blood pressure, high cholesterol, and high heart disease, which is often seen with what's called metabolic syndrome. There's an increased risk of diabetes mellitus, infertility, and due to the estrogen long-standing or like the elevated doses of estrogen in the body, it can lead to precancerous changes or cancer of the uterine lining. So it's important to diagnose this and be aware of all these potential issues. So what does the BC Women's Center for Pelvic Pain do? So we have an interdisciplinary team format. So an interdisciplinary team is defined as a group of healthcare professionals of varied disciplines who work together at the same physical site, sharing in a decision-making process based on everyone's different inputs, and then discuss the course of treatment, share the same goal and approach to pain management. So I find that it provides a lot of different perspectives to an individual. And the important thing is that we also use the same records so that we can actually see what the other person has said, and so that we can reinforce the message over and over again. At our center, we have 6 gynecologists, two gynecologists who are fellows, so they're doing extra training to become, to do the same things that we're doing. We have pelvic floor physiotherapists, psychologists, and 2 registered nurses as well. Why do we have such a model? We provide holistic evaluation and treatment. So we account for personal factors, cultural factors, social factors, and economic factors. And then this allows us to have a consistent language and message throughout. And then it's the most effective system for pain management. And some of our examples come from low back pain, where interdisciplinary care was found to be superior to usual care, and it allows for greater improvement in pain and function and earlier return to work and patient satisfaction. At the we're a center of expertise on endometriosis. We're one of 4 in North America. We provide comprehensive evidence-based care for female individuals with advanced stage endometriosis, so the advanced laparoscopic skills, and then complex pelvic pain conditions that are problems that are not responsive to standard treatment. The components of our evaluation include evaluation with what's called pain mapping. We provide a diagnosis, and then we talk about the treatment. So I'll show you this diagram here. But before a person shows up in our clinic, we always start with a validated questionnaire. So everyone who comes through our clinic fills out a full 2-hour, it takes 1 to 2 hours questionnaire going over their history. And then we look at how endometriosis is impacting quality of life, whether or not there's issues with depression and anxiety, and just looking at it. And I find that really helps us to be on the same page from the very beginning. When you come to see us, we do a history and physical examination and pain mapping. And so I find that the pain mapping is very validating for different individuals because it tells us exactly where the pain is coming from. And then we find that there's actually a good correlation with where the pain is and where we find endometriosis. And then our ultrasound that we do in clinic, I always turn the screen towards the person being evaluated. And what I do is I show them, this is what the uterus looks like, this is what the ovaries look like, and we go over what the normal anatomy is, and then also where the pain is. And so we're able to predict how severe the endometriosis is going to be by doing this evaluation beforehand, and we can prepare appropriately. Our clinic also, based on the first appointment, we also talk about whether or not people would want to participate in our program. And so we offer an interdisciplinary pain program where there's an educational workshop where we talk about pain neuroscience. There's an introduction to mindfulness and physiotherapy, like we talk, like it's offered here, and then talk about lifestyle changes. In terms of other factors, we have a psychologist now who will be working with us. And so that's that we provide 2 to 4 sessions that are all MSP covered. And we talk about, we provide resources on cognitive behavioral therapy, acceptance and commitment therapy, and mindfulness-based stress reduction. And then we address all of the psychosocial factors, community resources. And then for physiotherapy, we do some this evaluation of bowel and bladder function, sexual function, and really work to try to increase that type of, to increase function from that point of view. And then it ends up being a tailored treatment plan afterwards. We also provide medical management. So the specifics, this really depends on the individual. So we won't go into too much detail, but we offer the different levels of hormonal therapies, talk about neuromodulators like amitriptyline or duloxetine, which are antidepressants, and then surgical management as indicated. And then we come up with a plan to, we follow up and then come up with a plan together, discuss individuals who go through our program at the team meeting, and we come up with an extensive plan afterwards. And this is our results. So we found that at baseline, most people had severe pain, and that follow-up, it decreases to moderate or mild pain. And this is our 1-year outcome at our clinic. And then we're also working in advocacy at different levels. So we're working to improve access to integrated endometriosis care through our fellowship program. And we do take 2 fellows per year with the goal of trying to disseminate our center. We also provide preceptorships for family physicians, gynecologists, and pelvic floor physiotherapists. And then we practice ongoing research with the goal of practicing the most advanced, effective, evidence-based care. And then we have been actively working on increasing awareness through educational outreach and residency education. And it's getting to the point where all our residents are very aware of endometriosis and how to evaluate that appropriately. And our final goal, which is a passion of mine, is to improve access to high quality preoperative imaging through collaborations with radiologists. And I'm working on several initiatives to try to increase the training for endometriosis across Canada, or across BC, and then later Canada as well. And then we've been doing some national work, national advocacy work through initiatives such as the Endo Act, where our Dr. Catherine Allaire, medical director, has been able to talk before the House of Commons in order to increase awareness of endometriosis. We'll move on to vulvar pain conditions. So vulvodynia. What is vulvodynia? So before we get started with that, I wanted to discuss what the vulva is. And so what people commonly call the vagina is actually the vulva. And so the vulva refers to all the external structures here. So this is the labia majora, which is a hair-bearing lips. Labia minora is a hairless lips. And then this is called the vestibule, which contains the urethra and the opening to the vagina. And the clitoris is at the top. And the vagina itself is actually the passageway that leads to the cervix. So it's that long tube. And so, like I said, most people, when they're talking about their vagina, are actually referring to their vulva. So vulvodynia is pain or discomfort of the vulva for greater than 3 months without a clear cause. And the way that the pain is described is not really uniform. It can be anything from sharp stabbing pain to burning, a ripping sensation, pulsing sensation, or itchiness, chronic itchiness. And what I mean by this without a clear cause is that this pain is not due to infection or an inflammatory condition or trauma. How common is it? Most places estimate between 7 to 16%, with 16% being thought to be more accurate, and typically impacts those between age 20 to 40. And the types of vulvodynia, there's localized, so it depends on location. So there's generalized, which means 2 or more locations. And then localized is where it's occurring in one location. And we also talk about triggers as a way to classify or vulvodynia. And so spontaneous is where it occurs all the time. Provoked means it occurs only with contact, and mixed is a combination of those. The most common ones are generalized vulvodynia and provoked vestibulodynia, where provoked vestibulodynia accounts for about 80%, and generalized vulvodynia just under 20%. So provoked vestibulodynia means pain of the vestibule here with contact. And then generalized vulvodynia means usually refers to pain that is occurring all the time in the vulva itself. How does it present? So provoked vestibulodynia presents with pain only with contact with contact of the vestibule, whereas generalized vulvodynia, the pain tends to occur spontaneously in multiple locations and can be either constant or intermittent. Often people think that they might have a UTI or yeast infection with generalized vulvodynia, but then what happens is that you go for testing, it always comes back negative. And the reason for this burning sensation is because the urethra sits just above the vagina, and that part is where the vestibule is. And so people often get pain with urinating, pain with sitting, or pain with standing for long periods of time, or anything that involves a lot of friction. Mixed vulvodynia is where you get a combination of both, and so spontaneous pain at baseline and worsening pain with touch. Often the vulva always looks normal, except maybe a bit of redness. So associated changes, there's avoidance or fear of intercourse, there's pelvic floor tension and pain, like we talked about at the very beginning. And if you look here, the muscles are very circular and it's a figure of 8 shape. And so when it is contracting, it leads to a narrowing of the opening of the vulva. And often people say that it feels like someone's hitting a wall whenever they're trying to have intercourse. And vaginismus refers to that as an involuntary fear response, where the muscles contract in response to any anticipated pain. And then the pain tends to worsen depending on emotional and physical status. So if you're more stressed or if you have other pain conditions that are flaring up, it tends to cause more pain. How's it diagnosed? It's based on the pain story. So we identify characteristics of the pain. We see if there are any other reasons for pain. And then we review the vulvar hygiene regimen. And then we look for, like, on the physical exam, whether or not there's any signs of infection. We might get a vaginal swab to rule out overgrowth of bacteria or yeast infections. We look for other skin conditions like eczema or psoriasis, cancer. And then look to see if there's any evidence of nerve injuries or inflammation, trauma, and then hormonal deficiency. So you might notice that the tissue is a lot thinner if you're menopausal or if you're breastfeeding. The diagnosis that we always rely on is a Q-tip test thereafter. So this is where we use a Q-tip at different areas to see if that elicits pain. And then we look at the pelvic floor to see if the tone is increased and whether or not there might be any other reasons for pain. Some challenges in vulvodynia include societal issues where there's a stigma of sex and lack of sexual education. In the healthcare system, there's issues with a lack of awareness of the condition and resources and dismissiveness of symptoms. And so some people have said things like, I know that this condition is not life or death compared to a tumor, but this is very important to me and it affects every single aspect of my home life, work life, and emotions. And so there may be instances where a physician says, why are you worried about this? This is not a cancer. You should just suck it up, or told to drink wine and relax. And I think that dismissiveness really leads to a lot of hurt and doubting of your own symptoms. In terms of individual issues, there's a lot of self-doubt where up to 40% never seek care. And there's a normalization of all the symptoms by the individual, saying that I just need to get over, I need to push through it. And there's also a lack of access to resources, because what usually helps is physiotherapy and counseling, but not everyone has access to that. And so there is the VC Center for Vulvar Health where I used to work too. And what we do at the Vulvar Pain Assessment Clinic is an interdisciplinary team, and it's a dedicated vulvar pain assessment clinic designed to evaluate and provide comprehensive management plans. And so the team consists of 2 gynecologists now and 1 gynecology fellow. They do pelvic floor physiotherapy with someone who has expertise in biofeedback, and I'll talk about what that is in a second, and a psychologist. And like endometriosis, interdisciplinary teams result in pain improvement more than standard treatment. And so the approach to evaluation and management is the gynecologist starts by providing a name to the pain, and rather than it being this nebulous condition. Having a name really helps with that first process to healing. And then there's an initial education step. And so we talk about different things to promote vaginal hygiene. So that might include avoiding soaps on the vulva, avoiding the Always brand. So Always brands for pads tends to actually cause more irritation, and moisturizing the vulva itself. If it's appropriate, then we provide the next steps in evaluation with a psychologist and physiotherapist. And then there's a second gynecologist appointment afterwards where a comprehensive individualized managed plan is created. And it's really about goal setting and making the plan really specific to the individual. And then we provide a list of resources. And then they also have a series of vulvodynia education seminars that people have access to. And so, like I said before, the central components is skincare, symptom management, and estrogen might be required, especially in those who are taking hormones, for example, or if they are menopausal, or if they're breastfeeding. We find that estrogen is essential because it provides a little bit more thickness of the tissue and prevents the nerves from being so close to the surface. The other component is pelvic floor dysfunction. And so we talk about pelvic floor exercises, perineal massages, and inserts. And if you look on the screen on the right, this is what biofeedback involves. There's usually what happens that we put two stickers on the individual. So one's around the anus on either side, but not internally. And there's one on the thigh. And what we get different people to do is to actually contract the muscles, relax the muscles, and try to get you more in tune with the muscles so that you understand what happens when you tense the muscles and what it feels like to relax the muscles. And the most common thing that we see happen is that the pelvic floor muscles have no ability to relax and is always contracted. And so a lot of people find this really educational and helpful because it helps you get in tune with your body again and promote that mind-body connection. The psychologist helps to address some of the negative thoughts, feelings, and behaviors associated with intercourse. So I often find that with my patients when I saw them is that people get into this negative cycle where they are anticipating intercourse, and they find that when there's some foreplay or any sexual like contact, they're already on edge, and then they start to avoid even that type of touch, like cuddling, kissing, that type of thing. And then once their nervous system starts to get more and more heightened, then they're more likely to feel pain and have negative associations with pain. So I think one of the hardest parts about vulvodynia is the breakdown of relationships that can occur with this. And so there's a lot of education, challenging negative thoughts, and relaxation exercises that we discuss. And then we talk about sex education, how to schedule sex, and how to improve, like how to realize what makes you feel good. So that's the sensate focus exercises. And so they do a lot of advocacy as well. So they also want to improve access to integrated vulvar care through the postgraduate fellowship program that they have. And they take one fellow a year for that. They provide preceptorships for family physicians, pelvic floor physiotherapists, and psychologists. And they provide ongoing research, and then they do increased awareness through educational outreach. And recently they were able to be part of the residency curriculum. So there's some increased recognition this way. And then they provide support for family physicians by creating educational tools like what's seen on the right. And then advocacy and awareness through their Instagram account, which has 13,000 followers now. And so this is the end of my talk here. Thank you for your attention. And if there's any questions, I'm happy to answer them. Okay. Should I just go ahead and answer the questions?
Absolutely. I think you've got 23 questions so far.
Okay, sounds good. Okay. So first question is asking about yoni steaming. So I think part of the yoni steaming has become more popular because of Gwyneth Paltrow, but for the steaming component, we find that there is no benefit for that in terms of improvement. So if it is something, as long as you're not using heat, if you wanted to pursue, that's fine, but there's no clinical benefit that we've noticed in our own experiences. And then the next question is, what is the difference between pain from interstitial cystitis and the pain from endometriosis? Um, so with and so what I often have see with endometriosis is that endometriosis usually comes first when there is when you have both symptoms. So endometriosis tends to occur with that painful period in the beginning, and as your pain worsens and your nervous system becomes more impacted, people start to develop bladder symptoms at that time. And so um, sometimes the pain can be due to endometriosis if there's endometriosis inside the bladder, but more often what's happening is that it's the nervous system taking over and impacting the way that the processing of bladder symptoms is like this is usually a change in the way the body perceives the bladder. So it is possible to have both together, but usually the cause initially is endometriosis. And so can one have very painful periods without endometriosis? Could there be any other cause for extreme pain during periods? So someone can have very painful periods without endometriosis being present for sure. Often people with PCOS tend to report having very painful periods. We don't know exactly why that occurs, but we think it might be due to the chronic chronic inflammatory state due to estrogen. Another reason for that would be adenomyosis. And finally, some people just don't even have any real reasons for having the painful periods in the first place, other than it being part of the nervous system being overactive. And so, but in that case, we think that one of the reasons why the periods are so painful is because the uterus has more nerves within it. Mm. And so, do you have any recommendations for how to explain these symptoms and advocate for yourself to get a referral to a specialist? I've had all these symptoms for years and asked for help, but have been brushed off. And so this is an ongoing challenge that we also struggle with. And so like one of the ways that I would bring it, I think that if you have a name that makes it the easiest. So if you know that you can say, I suspect that I have endometriosis and say why you think that, then it might be a trigger for a person to think, oh, maybe this is endometriosis. But sometimes like it is just a matter of advocating for a referral to a gynecologist first and saying, I think that if you are a little bit more empathetic or emphasize that you need to see a gynecologist to look into endometriosis, that's one of the first steps. And I find that the ways to describe the symptoms is to say, like, I have had very debilitating periods that are impacting my quality of life and my ability to work. And then I also have the symptoms commonly associated with it, including it could be like painful intercourse, painful bowel movements. And I think that that will help to kind of trigger that thought in the person who is looking after you. But I hear you. This is a very difficult situation that I've heard numerous times from a lot of different individuals. Um, for ultrasound, is there an optimal time for the cycle to be screened? Can just an external ultrasound detect endometriosis? There's no, theoretically, there should be, the most optimal time is when you're having your period. But often people don't like to have their ultrasound then. But in practice, I find that it doesn't really make a huge difference because if there's any damage associated with endometriosis or scarring associated with endometriosis, I can see it no matter what time in the cycle you have it, or no matter what time in the cycle you have an ultrasound. And then the external ultrasound probes are not as accurate in detecting endometriosis. I know that not everyone can tolerate the probe, but what the external ultrasound can show is whether or not there's endometriosis in the ovaries, and that's diagnostic for endometriosis. Are there any studies I could show work safe about ME, FS, CFS, and POTS? I think if you look at my references, I have a list of articles I've read. So I think Dr. Arsenault is sending out my presentation. Have you received it, Rick?
Yeah, we're going to be sending it out.
Okay. So I think if you look at that list, there should be some resources there. Um, How do we find radiologists who specialize in endometriosis? Um, I find that I've been working really closely with the Vancouver General Hospital group, and the radiologists there have a lot of experience with endometriosis. But we are working with other groups like Greg's Imaging and other centers to try to improve the endometriosis imaging techniques. So this is something that we're working on, but right now one of the best places is to go to Vancouver General Hospital for imaging. How can I manage PCOS without birth control? What's the best way or what best birth control? I think for PCOS, it can be numerous factors. We do know that weight loss of 5% can lead to restoration of the cycles and then a decrease in the insulin resistance. Another way that people have found effective changes is to do things like using metformin to help with that. Other ways, if you don't want to be on birth control pills long term, is to just use the progesterone every month so that you can induce a period once a month to prevent the overgrowth. If you do use a birth control pill, all of the birth control pills are pretty similar in effectiveness, so I don't have any specific recommendations for that. Do painful periods always mean that there's a problematic condition? Not always. There is a baseline level of painful periods that people can experience, but it's when it's experienced as being debilitating and interfering with your daily life where it becomes a concern. If you're able to manage the symptoms by itself, then you don't need to necessarily seek treatment or a diagnosis. But if it's pain where to the level that is interfering with your daily activities, then that is where you think about endometriosis or adenomyosis. Would you have basal body temperature changes with PCOS like you do with ovulation and the start of periods? If you're not ovulating, then you won't have the basal body changes. And with PCOS, because the cycles tend to be so long, sometimes people do ovulate eventually, but it could be that you're waiting sometimes 60 days, 90 days before you have that basal body temperature change. But the trigger for that basal body temperature change is the act of ovulation. How accurate is the endometriosis diagnosis when there is an endometrioma found on ultrasound without surgery? There was a systematic review meta-analysis that was done on endometriosis, and they found that ovarian endометрiomas are diagnostic for endometriosis. So in our clinic, we treat that as a clinical diagnosis of endometriosis. Usually endometriomas have a very characteristic feature. So when you see that, you can pretty much guarantee that's endo. So is a laparoscopic diagnosis of endometriosis considered the gold standard globally, or would MRI be a gold standard if there are sufficient specialists trained to read MRIs? Right now, all the guidelines across the world have endometriosis surgery listed as the gold standard, but there have been calls from the endometriosis specialists, like the endometriosis societies, to change that so we make more of a clinical diagnosis of endometriosis. Because if you take a really good history, so like when you go through the symptoms really in detail, and if you do a really good physical exam and ultrasound or MRI, we find that that is sufficient to give you a 90% accuracy for endometriosis. So I think that in my lifetime, we're going to see that there's going to be a movement towards MRI as gold standard or even ultrasound as gold standard later, rather than having to go through surgery. And a lot of people in endometriosis advocate for a clinical diagnosis because this prevents the delay to treatment. How long is the wait time to get into BC Women's? Currently, we're sitting at a year, but if you have more advanced endometriosis, we are saying we try to see everyone within 3 months. If you're already a patient of another BC Women's program, can we be referred internally? Unless you're part of the BC Women's Center for Chronic Pelvic Pain, there's no internal referral, unfortunately. Are there any pelvic floor physiotherapists who have trained at BC Women's, and would you recommend that you would recommend in Comox? So actually, our physiotherapist has put together a list of physiotherapists that kind of align with our philosophy. So if you want a copy of that, I can send it to maybe Rick. Would that be okay, Rick, if I sent you a list of that?
Absolutely.
Okay, okay. Because I have a list from the BC Volver Health Center, but also from our own physiotherapist. So I'll send out that list as well. Um, okay. So what would you recommend? So I think like the one question is about gender transition for someone who's taking testosterone. We often find with testosterone, there may be an improvement in pain with that. And also like what we screen for, what we're seeing more and more in our clinic is that if you have really low testosterone levels, that tends to impact your energy. And so we have started to use a little bit more testosterone in our patient population, especially in those who are menopausal. So there may be some role for testosterone for pain management and also for energy, but it's not a well-studied population currently. And but they are using a lot more in Australia, for example, than here. Mm. Could you explain more what a pelvic floor physiotherapist can help with and the biofeedback they give? So there's two different kind of ways that there's a couple of ways that the physiotherapist can help. Our pelvic floor physiotherapist teaches us different exercises that you can do during intercourse to help with the pelvic floor muscles. And so the real goal, a lot of the goals of the pelvic floor physiotherapy is to get you more in tune with your body again and learn what it feels like to relax the muscles and provide more of that control, because the state that tends to be the most common is for the pelvic floor muscles to be very tense. And so that can contribute to pain by itself, but also during intercourse, the tendency is for people to contract their pelvic floor muscles. And so if you learn how to relax it, then it can improve some of the pain that you get with intercourse. The other thing that our physiotherapist works on is finding out more about your bowel pattern. So she gives a lot of resources on how to manage IBS symptoms and also painful bladder syndrome. So how can we manage that, and how can we increase the function of the bladder and the bowel? For biofeedback, it's the same thing where you try to get more in tune with your body, but the other component is really to desensitize the tissue by kind of touching the tissue in a way that is safe, but then you can start to slowly increase that, how often you can touch that tissue, and then trying to use vaginal dilators to help open up the vulva a little bit more, or vagina a little bit more. So and then the last thing that my pelvic floor physiotherapist really is good at is also teaching some strategies to help with the pelvic girdle, because often what happens when you have pain is that you hold yourself in certain ways to accommodate that pain, but then that becomes an independent source of pain. So we really work on posture and how to support the pelvis so that you're not causing trauma over and over again to the pelvis. Is there a birth control that doesn't have cancer or stroke risk? So I think with birth control pills, we actually find that there's different things associated with birth control, but with the birth control pills, if you're on it for 5 years, it actually reduces the risk of ovarian cancer by 50%. And then if you're on it for 10 years, ovarian cancer by 75%, and also has a risk of actually improves colorectal cancer by a significant degree as well. The things that we worry about is breast cancer. There hasn't been any studies that actually show a link between breast cancer and birth control pills definitively. What they have found is that breast cancer is more likely to be detected, but it's not that you have a higher risk of developing breast cancer per se. And the stroke risk is something that is definitely a concern. Usually though, like being pregnant by itself is actually there's a higher risk of stroke than birth control pills. And so, but if you wanted to avoid the component that is more associated with that is avoid hormones that are associated with strokes, is to avoid something with estrogen in it. Um, Can you speak about the connection between endometriosis and fibroids? There is, with fibroids, see that about 20 to 30% of individuals with endometriosis also have fibroids, but we don't know exactly why. But then, so there are instances where we see the three different conditions like endometriosis, adenomyosis, and fibroids together. But fibroids are by themselves are not usually a cause of pain. It's just that it happens to be there at the same time. Would you recommend getting preventative ultrasounds every year or so for endometriosis? There's some people who have endometriosis and never get diagnosed with it. So I often find that it's better to just go to undergo these images if there is evidence of pain or if there is a pre-existing endometriosis. And then, so this one question asked about if there's a there's a correlation between ME, CFS, and endometriosis. Are there correlations between the other pelvic conditions discussed today and the ones that Dr. Arsenault focuses on? I do find that there's often quite a bit of correlation with any kind of chronic pelvic pain condition and ME, CFS. And I also find that in individuals who have more severe pain, that there's an association with POTS. There can be an association with fibromyalgia. And so there's quite a bit of overlap between this. And this is part of the reason why I wanted to kind of initiate the discussion with Dr. Arsenault here. For central sensitization driven internal vaginal neuropathic pain or hypertonic pelvic floor, are there any other options than pain education and paying out of pocket for pelvic floor physiotherapy? How often should the endometriosis ovarian cyst be checked via ultrasound? So other options like things that we can do, there are different resources online. So I can get my physiotherapist to see if provide me with some of the resources and I can send it out to Dr. Arsenault again. Because there are some like different yoga exercises that have been recommended previously. And I know that this can be quite costly, so I can look into that. Endometriosis, ovarian cyst, it kind of depends on how big the cyst is and the characteristics and how quickly it's growing. So I can't make a specific recommendation on that. We still use high-dose Depo-Provera to treat endometriosis. We haven't actually found good results with Depo-Provera, so we've been avoiding that. But the common medications that we use is Visan or Dynagest and Norlutate, which are just progesterone-only medications. But with Depo-Provera, in our population, we try to avoid any medications that has a long-lasting effect because Depo-Provera, you're supposed to get that every 12 weeks. And we find that if you have we don't know how any individual is going to respond to any medication. And we don't want something that stays around for 3 months if you have an awful response to that. So that's why we tend to use medications by mouth. What can help with endometriosis if you cannot tolerate any oral hormonal therapy and Mirena IUD is already in place? Is laparoscopy indicated? And this is one thing that we do like part of the reason, some of the indications for surgery would be if you're finding that you've tried medications without there being any benefit, or if you're not able to tolerate the medication, that's when we do offer surgery. And then another indication would be if you're having issues with infertility, it seems to improve outcomes after that too. So especially if you've had previous good results with it, there can be a place for a laparoscopy in that situation. Is it likely or common for endometriosis cells to grow in the brain? There hasn't been any evidence of that in the it's more likely that it kind of involves the organs more locally, and the rare places that it has shown up is in the lungs or in the sciatic nerves, but there hasn't been any reports of it being in the brain. Mm. This one question is asking about a tight pelvic floor muscle. And if you, so for vulvodynia is actually pain of the actual vulva itself, but pelvic floor muscles are just seen as a bit of a separate condition. So if you have pain when you touch any of the external organs that or the external components of the vulva, that's considered vulvodynia. And if you have that, then you can get medical advice on it. If you have tight pelvic floor muscle and that's painful, then pelvic floor physiotherapy tends to be the best route. But like the BC Vulvar Health Clinic or Health Center does accept referrals from family physicians directly, so that is a potential route to go to. Yeah. I think I've gotten to the. Okay, this is one question about ovarian cysts, and then I think that's going to be my last question. But this person has had ovarian cysts when they had bad pain, and then in a repeat ultrasound, it was gone. So what would that be? So sometimes like the actual process of ovulation itself can be painful, and sometimes the painful ovulations is due to endometriosis. So that's something that may be worthwhile looking into, especially if you have an underlying history of painful periods as well. Fibroids as a cause of pain with intercourse. It's unlikely to be fibroids unless it's like really low down, but fibroids themselves tend not to be associated with pain overall. Okay. Oh, there's more now. Is it possible to experience bouts of PMDD while in depot? PMDD is usually due to that the fluctuating progesterone levels, but it is possible to have symptoms of PMDD even while in depot if there's incomplete suppression. But part of it could also be that the Depo-Provera is causing the depressive symptoms because it's a progesterone as well. And is there a hereditary factor for endometriosis? Yes, we think that there is a hereditary factor where it seems to run in families, but it can also happen kind of spontaneously. I've been taking Vizan for 4 months and it's been working so well, and then switched to the generic Dynagest. I've heard that happen before. It might just be that there's just subtle differences in the formulation of the medication. That's why it works really well for some people. But I've seen the opposite happen too, where people went from the brand name Vizan to the generic name, and then they found that it worked better. So everything is very individual, and it's hard to say why. But I think if you had good results with the brand name Vizam before, I'd go back on that. To get a referral to the BC Vulvar Health Group, what steps does a family physician first have to do and rule out? I think, I guess, is whether or not the first thing that they have to do is whether or not say whether or not there is vulvar pain and that the yeast infections and bacterial overgrowth has been ruled out. And then the second step is much more helpful if you actually see that the family physician has done that Q-tip test that I showed. And then that really helps for you to get that referral there. This last question, I have chronic pelvic pain and recurring polyps. I've been surgically removed 3 times. No formal diagnosis. If you have been seeing gynecologists in the past, we do accept referrals in that situation, but so you would be a candidate if you're not menopausal, but it's hard to say without knowing your full story. I think that's it.
Excited for questions? Perfect. Thank you so much, Dr. Lee. And if you send me the slides and the list, I'll forward those to the patient.
Okay, sounds good.
Thank you again. Have a great week, everybody.
Thank you.